Okay, everyone, thank you so much for coming to our trainee rounds today. My name is Dominic Alley. I'm the communication specialist for T-CAIREM. And just to let you know, these are competitive trainee rounds. We have our two trainees who will be presenting. Each will present for 20 minutes, and then we'll allow questions for the last 10 minutes of each presentation. We're really excited. And first up, we have Zeinab Navidi. Ms. Navidi is a first-year PhD student in the University of Toronto's Computer Science Department. Her background is in computer engineering, and she was a research assistant at the University Health Network Institute prior to starting her PhD program. She's worked in a variety of machine learning applications ranging from single-cell analysis, medical images, and most relevant for today, predicting patient outcome based on clinical variables. Ms. Navidi is incredibly passionate about applying her AI knowledge to real-world health problems. And in her PhD project, she's working on decoding drug effects on single-cell genomics. And we're delighted to have her.
Okay, thank you.
Yep.
Thank you so much for the opportunity to present our work, machine learning to identify predictors of heart transplant survival. My name is Zeinab Navidi, and this project is supervised by Dr. Bu Wang, an AI scientist from Vector Institute, and Dr. Mitesh Badiwala, a heart failure surgeon from the Division of Cardiovascular Surgery at University of Toronto. Previous studies looking at mortality after heart transplantation have shown that there exist multiple phases. These phases are impacted by a myriad of variables representing recipient, donor, and operative variables that have a complex time-dependent relationship with mortality. Understanding this relationship would be helpful to inform risk mitigation, as it will allow practitioners to tailor their approaches based on the time from transplant. Considering the significance of patients' lives, we have become interested to investigate patient samples in order to learn important variables impacting their survival after heart transplant. To that end, we had a three-parted objective in this project. First, we would wanted to model early and late phase mortality using recipient, donor, and operative variables. We then aim to understand the time-dependent relationship between these variables and heart transplant survival. And finally, we'll look into the models to identify the important predictors that impact early and late phase mortality. This figure shows our overall study workflow. We included 587 patients that had heart transplantation at the Toronto General Hospital from 1987 to 2017, and there were a total of 26 variables that were included in the modeling. The overall mortality rate amongst our cohort was 15%, and in keeping with the phasic nature of mortality, 70% of it took place within the first month after transplant, which basically was our main motivation to develop separate sets of models for early, which refers to 1 month, and late survival prediction, which refers to 1 year. We performed data cleaning, imputation of missing data, and normalization. And using 80% of total samples, we trained 2 sets of models to predict binary label of survival in 1 month and 1 year. The reason why we use machine learning in this circumstance is the high degree of collinearity between the variables and the data-driven nature of our methodology. For model evaluation and interpretability, there were 3 evaluation measurements performed on the held-out test set. First, we determined the quality of actual modeling by comparing their area under the receiver operative characteristic and sensitivity. We then used an interpretability platform called Shapley Additive Explanations to open the black box and provide a ranked list of important variables, both in direction and magnitude. We then used these SHAP values to generate importance trajectories for each variable and compared their importance and relationship with mortality over time. I will dive deeper into the details of each of these steps in the following slides. In the data pre-processing, we perform multiple steps of cleaning in the course of time with a continuous feedback from our clinical collaborators. We generated the Pearson correlation of features and only kept one variable from the pairs having correlation higher than 17. We then removed variables that are a combined metric of raw measurement and also the end stage markers of disease and thus less informative. Next, we performed imputation of missing data with the average value for continuous variables and mode of categorical variables. And then normalize the train and test samples with the mean and standard deviation of training samples and converted them to mean zero and unit variance. We normalized test data with trained sample statistics because the assumption is that test data can be any external data set and we only can process it based on our training samples. We then perform t-tests between the variables of train and test cohorts to make sure there isn't any significant difference between these variables. Here is a list of variables we ended up including in the modeling, categorized into 3 groups of operative characteristic with 4 variables, recipient characteristic with 19 variables, and donor characteristic including 4 variables. As mentioned earlier, only 15% of patients died before 1 year, which means that there was a data imbalance between 2 classes. Considering this challenge, we employed multiple techniques to improve the performance of our machine learning models. These techniques include randomly oversampling the minority class, randomly undersampling from the majority class, considering weight for classes based on their distribution, and developing a balanced random forest ensemble model by randomly undersampling each bootstrapped cohort to balanced class distribution. So the best performance for early phase models were obtained using undersampling each bootstrap data in the random forest, and for the late phase models by using oversampling technique. Here is a visualization of our modeling. The inputs are filtered pre-processed clinical variables, including recipient, donor, and operative variables in the tabular format. The true labels were obtained from patient history provided, and we labeled the patient as not survived only for those whose death label and its exact time were available. We originally trained multiple different machine learning algorithms, and random forest, which is an ensemble model, performed the best among all. Logistic regression is the standard predictive analytics that are used mostly in clinical prediction. We included the result from logistic regression for comparison with the base model. We developed a total of 8 models, 5 for early phase mortality prediction and 3 for late phase survival prediction. The early phase models predict patient survival before 1 month using variables available at 1 day, 2 days, until 5 days after the operation. And late phase models predict survival before 1 year using variables available at 1 month, 3 months, and 6 month time points after heart transplantation. We used 5-fold class validation algorithm for training and tested our models on the held out test set from our data splitting. And the output is a binary classification label whether a patient survived or not. For more details of the modeling, we first performed grid search by optimizing recall metric to find the best initial set of parameters on the training set before performing cross-validation. We then used 5-fold cross-validation on 80% of all data and developed 5 different random forest models, each trained on 4 out of 5 splits and validated on the 5th split. For testing, 500 bootstrapping were performed, and for each bootstrapped cohort, which were randomly selected from the test set, we predicted survival with all 5 models and used the majority vote algorithm to obtain the final prediction. The final prediction then were used for the evaluation and further experiments. And using the prediction from all bootstrapping samples, we also generated confidence interval for the evaluation metrics, which will be presented in the following slide. Here we see the model's performance on the held out test set for area under the receiver operative characteristic and sensitivity analysis, comparing logistic regression and random forest models over time. In the y-axis of the figures, you can see the value for each metric. And in the x-axis, there are different models using different variables at different time points. Same variables at different time points. In both early phase and late phase model, we can see that random forest has higher performance with regards to both metrics, and its performance improves with time within each phase. We can also see that with time, there is a significant outperformance of random forest compared to logistic regression in 1 year survival prediction, which indicates random forest's potential to learn survival patterns more efficiently. You can also see the 95% confidence interval for both metrics, which are obtained from 500 bootstrapping and averaging the scores of 5 cross-validated models on each bootstrap cohort. Overall, the confidence interval for random forests were much higher compared to logistic regression. We also generated another metric, net reclassification improvement, or NRI in short, to see the improvement of random forest compared to logistic regression. The NRI for all the models at different time ports are demonstrated in the right figure. So value of 0 means that there is no difference between the prediction of two models, and the larger positive value meaning that random forest has more correct reclassification compared to the base model. We can see that with more information available, NRI is overall increasing with time. In order to interpret the trained models and understand to what magnitude and what direction each variable impacts the prediction, we used Shapley additive explanation, or SHAP values, to open the model black box. These two figures show the early model using 5-day variable and the late model using 6-month variables. We observed that 7 out of 10 highest ranked variables are common for both early and late phase prediction models. And those that are marked in pink are different significant variables for each mortality phase prediction. We looked into all variables with our clinical collaborators to make sure the direction and the magnitude of them are clinically valid. Here we see the trajectory analysis performed. The figures show the feature importance rank of variables in y-axis in 3 categories for each of the 8 models that was developed and are shown in the x-axis. On first glance, we can see that the recipient characteristics are the most important to predict heart transplant survival, followed by operative variables and finally donor variables. First, when we look at all the plots, we can see that recipient variables are more important throughout the life course of patients, versus donor and operative variables lose importance over time. Among recipient variables, the presence of renal failure is a persistently important variable and is represented in multiple ways, such as pre-transplant creatinine and chronic renal insufficiency. Variables that represent rejection and side effects of immunosuppression, such as cardiac allograft vasculopathy, or CAV, and also presence of infection, gain significant importance with time. There was one added variable for the late phase survival prediction compared to early phase models, which is demonstrated in brown color and indicates the highest creatinine within 1 month post-transplant. Our models show that this variable plays a significant role in late phase mortality prediction. Amongst donor variable, large heart size mismatch has an impact on early phase survival, but loses importance over time in the late phases. As the equation indicates, the predicted heart mass ratio is calculated by dividing donor's PHM by recipient PHM. And larger values mean larger donor heart compared to recipient, and smaller values mean smaller donor heart compared to recipient. To summarize the result, when we look at the time-based survival modeling of heart transplant patients, We can see that random forest has higher AUC and sensitivity compared to logistic regression with incremental gain in late phase mortality prediction. When we look at trajectory analysis findings, we observe that donor and operative features lose importance over time. We also observe that predicted heart mass ratio was the most important donor variable, while overall recipient variable remain important for both early and late phase mortality. And recipient renal dysfunction is an important variable that remains important for both early and late survival modeling. And lastly, an interesting finding of our study was highlighting two significant variables, chronic renal insufficiency and pre-transplant creatinine, which have been underemphasized in the literature and need to be considered for further clinical examination and interpretation. This study discusses and informs risk mitigation in patients by identifying the contributing factor to mortality and the timing at which modifying these factors would be most effective. Clinically, the result of this study informs a dimension of time to risk mitigation in heart transplantation and should be appreciated when evaluating a patient. From a methodological perspective, machine learning ensemble approach that we trained in this study, or more specifically random forest, has shown significantly superior performance of survival prediction compared to the base clinical model. And our model was able to predict early and late phase mortality after heart transplant operation with high AUC and sensitivity. Also, we proposed a time-dependent relationship between recipient, donor, and operative variables over time. While we have obtained very good results from the data that were accrued at Toronto General Hospital, we are less sure and actually very interested to validate our model on external patients and see how they generalize. This leads us to the biggest limitation that we have faced regarding data. Boutique surgeries like heart transplantation are only performed at specialized centers, and it can be challenging to accrue data in a short time span. And specifically, we don't have a lot of data in Canada. Prolonged times of collecting data are challenged by changes in practice and incremental progress, which makes the data heterogeneous. So a way to address this would be to collect multi-center data for modeling, as different institutions have different clinical and surgical management, and it will give us insight into what are the best practices to manage patients. A new AI concept called federated learning would not even require the transfer of data between the institutions, as it relies on a traveling model that is updated by the data at each institution separately. So ideas like this can revolutionize the way in which we collect and report data for surgeries with high stake and small numbers like heart transplant. And for the next step, we are working on finding an external patient cohort to assess our model's generalizability. In conclusion, we believe machine learning has shown great potential in learning patterns of time-based clinical variables and should be considered as a form of survival modeling to identify patients at risk. And lastly, we would like to encourage Health Institute to share more patient data to facilitate collaborative learning. So with more institutes willing to share their samples, hopefully we would be able to develop more robust and generalized models to be used in clinical practice. At the end, I would like to thank my advisors, Dr. Bowang and Dr. Mtishwala, and my teammates for their support and contribution in this project, as well as funding resources. Thank you all for your time, and I would be happy to take any questions.
Oh, that was wonderful. Thanks so much, Zeinab. It's great to hear about such important research. Now, I'm going to turn this over to our three adjudicators for questions, and then the audience will get the opportunity to ask questions. So our adjudicators for today's two presentations are Dr. Benjamin Fine, Dr. Mamata Bhatt, and Dr. Rashmi Nadadar. So I'll leave it to the three of you to get your questions ready.
Okay, well, that was a great talk, Zeinab. So I'm Dr. Butt, so I'm a transplant hepatologist. And from what I understand, you've incorporated a number of different recipient variables. Did you consider immunosuppression and the immunosuppression regimens that patients were on and the impact on outcome?
I believe we had a few variables representing immunosuppression.
Yes.
Right. So basically, I believe one of the contribution and novelty of our work was splitting our features into these three categories.
Yes.
And variables that represent rejection and side effects of immunosuppression here are cardiac allograft vasculopathy or CAV, and also the presence of infection, which gains significant over time.
Did you look specifically at the types of immunosuppressants that a patient was on? So like heart transplant recipients would be on 3 immunosuppressants in general. So, and there might be changes in, say, the dose and the trough levels of immunosuppressant over time. So did you consider those, or are you planning to consider those?
I believe the information, like the patient history that was provided, wasn't including these details. But this is an interesting point to consider, and maybe we can ask our collaborators to see if such information is available. Thank you.
The reason I ask is because so we published a paper looking at the liver transplant experience. So we looked at the SRTR liver transplant patient population, and then so did training of our algorithm to predict post-transplant complications and associated mortality. And we then used our UHN data set as the test set. So in the UHN data set, we had more granular information regarding trough levels, et cetera. And we did actually find that, say, trough levels had an impact in terms of prediction of mortality. So this might be very interesting and relevant to your cohort, I think.
Yeah,
and
of course.
In fact, the SRTR is also has a wealth of information that you might consider interrogating as well. So the Scientific Registry of Transplant Recipients, which represents all US transplant recipients. So they have very good information, especially on the waiting list for transplant of all solid organ transplant recipients in the United States.
Yeah, thank you for bringing up this. We'll definitely consider this and follow up if we can access to this information, granular information.
I suppose I'll go next. I'm Rashmi. I'm a cardiac surgery resident who works at a Bowbank's lab. I work with Zeinab a lot. And so I am pretty familiar with this project. I guess I wanted to know from Zeinab, I felt as though you exhibited your workflow very well. I think that you showed how it is that you went from your data to your modeling to your output. And I fully recognize that you're not a clinician, so sometimes it's hard for you to comment on like the clinical significance of the findings of your modeling. But what I wanted to kind of understand from you was, why do you think random forest performs better than logistic regression in this specific circumstance? And why is it a graph that you showed over time, you showed that as more data accrues, random forest performs better? Why do you think this is the case?
So for the evaluation and actually for the model training, we optimized our recall metric because in our discussion with the team, we considered recall as an important factor to basically recall the patients who are really in danger of not survival. So we train our models considering this metric, and also we consider that as an evaluation metric in addition to area under the receiver operative characteristic for the evaluation on the held out test set. So based on the outperformance and the number and the percentage of patients who didn't survive by random forest compared to logistic regression, and the net reclassification improvement that we basically generated to see how many samples are correctly reclassified by random forest compared to logistic regression. We assume that we can see that how random forest performs better, and then we use the feature importances to kind of find time-dependent relationship between the different categories of variables, if that answers your question.
Sorry, thank you.
Not sure if we still have time for one more, but I can throw it out there anyways. So I'm Ben Fine, I'm a radiologist and clinician scientist at the AI Deployment and Evaluation Lab at the Institute for Better Health at Trillium Health Partners. Really appreciate being invited today and the presentation, so thank you. Zeinab, I guess my question is deployment oriented, and maybe some of your clinician colleagues might be able to contribute to this as well. How do you envision this being used in the clinical workflow, and kind of what decision do you see it enabling? And specifically, I asked that because you mentioned you presented two metrics of performance, mainly area under the curve, which, as you know, in imbalanced classes can be misleading, and then and sensitivity, which you seem to optimize for, including in your training. Maybe you could talk a little bit about how the decision was made, or how the discussion that you would have had around, what metrics you're trying to optimize for, given what kind of decision you want to make, because any highly sensitive, predictive tool is going to come with probably a high rate of false positives.
Sure, thank you for your question. I will leave them, so I can answer from my perspective, and then if Rashmi is also interested, can have her comment. So the main metric that we really cared about was recall or sensitivity, to find or to basically perform the experiment on the best performing model. And because we used different data imbalance techniques to basically oversample and undersample different class distribution to have the same number of samples. We also use area under the receiver operative characteristic for the evaluation. But the point that I also made in the limitation is that this method is only validated on the same cohort that we had on the held out tested, and we would be more interested for further clinical applying in clinical practice. We definitely would need to see how it generalizes to other external validation, external data set from other institutes. If that answers your question, or I would be happy if you want to more clarify it.
Okay, that's fantastic, Zeinab. Thanks so much. And we're just in time for our second presentation. Bonnie Chao. Ms. Chao holds a Bachelor of Applied Science from the University of Toronto and is now entering her third year of the PhD program in biomedical engineering at the U of T. She's worked in a variety of domains ranging from semiconductor processing, biostatistics, and biomarkers analysis, which leads to today's topic: radiographic analysis of donor lungs ex vivo. Ms. Chao is passionate about advancing diagnostics and health analytics using AI, as well as teaching, mentoring, and science communication. And we're delighted to welcome her.
Hi, thank you so much for the introduction, and thanks for the opportunity to present at this training round. My name is Bonnie. My presentation title is Computer-Guided Evaluation of Human Donor Lungs During Ex Vivo Lung Perfusion and How it Predicts Lung Injury and Lung Transplant Outcomes. This is the outline of the presentation. We'll first introduce our study background, lung transplantation, and ex vivo lung perfusion. We'll then go through a subset of our EVLP radiograph dataset and a ground truth labeling. And finally, we'll end with our proposed computational method of analyzing EVLP radiographs and some pilot results. Before we delve into the research study, let's get some background in lung transplantation. Like other transplantations, lung transplantation is the last intervention for those with end-stage lung disease. Among all the lungs donated, only about 20% is actually used, and even with this level of conservative selection, the median recipient survival time remains quite a bit lower than other solid organ transplantations. This is because donor lungs are prone to damages from ICU management, donor death, and organ preservation. These all lead to the development of primary graft dysfunction, which is an acute form of lung injury that significantly affects recipient prognosis post-transplant. In order to mitigate donor lung shortage, ex vivo lung perfusion, or EVLP, was developed to reduce donor lung injury by reconditioning lungs prior to transplantation. The top photo on the right shows a donor lung placed in a box of ice during transport, and the bottom photo shows the lung placed on EVLP. Our EVLP platform is shown in the middle figure. It contains a pump that pumps perfusate throughout the system, which contains molecules like glucose, electrolytes, and albumin. There's a filter to filter white blood cells from donor lungs. During perfusion, the temperature and flow rate of perfusate are gradually increased. The idea is that we're trying to simulate the body functions to support donor lungs before transplantation. But why do we bother setting up a complex system before transplantation? Well, by preserving the lungs at 4 degrees, we're subjecting them to cold ischemia, meaning the tissues are fixed and starved under low oxygen and nutrients. This is a major cause of donor lung injury, as we mentioned earlier, which in turn results in a significant number of lungs being discarded. When we put donor lungs on EVLP, we reduce the amount of time they're put under cold ischemia. In addition, we found that gradually rewarming the lungs protect them from mitochondrial damage and cell death during sudden temperature increases. On top of that, when donor lungs are under physiological conditions, active metabolism allows tissues to repair themselves. The success of EVLP led to the Health Canada and FDA approval in 2012 and 2014. To date, 830 clinical EVLP cases have been performed, with roughly 2/3 of the EVLP donor lungs being transplanted. The bar graph here is a little bit outdated, but we can see that while the blue bars remain more or less stable, the yellow bars have been driving the increases in lung transplantations. EVLP has expanded the number of donor lung transplantations since the first transplantation was performed in 1983 in Toronto. Survival curves on the right show the percentage of recipients alive on the y-axis and time from transplant on the x-axis. This graph further indicates that long-term lung transplant outcomes are not affected by the use of EVLP, which is indicated by the red curve. An important aspect of EVLP is our ability to directly assess donor lung quality without physical barrier or confounding factors from other physiological systems. These assessments pertain to the physiological, biochemical, and inflammatory aspects of donor lungs, and most of these wouldn't have been possible without EVLP. Additionally, we're able to take images and videos of just the lungs outside the body. These factors contribute to data that are less noisy and in turn breed the ground for potential machine learning applications. Moving along to our actual research study. We've mentioned the possibilities to evaluate donor lungs on EVLP. In fact, we recently built an algorithm using extreme gradient boosting, which takes in tabular data collected during EVLP and predicts recipient outcome. One aspect that we haven't really touched on is the imaging, specifically the X-ray images of donor lungs taken during EVLP. Traditional chest radiographs shown here are obstructed by the chest wall, ribs, or heart indicated by the red arrows. In contrast, EVLP radiographs provide an unobstructed image of the lung, as shown in the figure on the right. These two images show the same pair of lungs, one in the donor and the other one on EVLP. These EVLP radiographs provide a much cleaner view of the lung vasculature, as indicated by the green arrow, and it's even possible to identify individual lobes of the donor lung on EVLP. To date, there have been no studies that systematically evaluated and quantified findings in EVLP radiographs. As a result, the diagnostic value of these radiographic features remains unknown. In this section of the study, we sought to develop a method to score and evaluate EVLP radiographs. And we have around 1,400 radiographs in total. Here we investigated a subset of 214 radiographs from 113 double lung EVLP cases performed between January 2020 to May 2021. These radiographs were taken after about 1 and 3 hours of perfusion. We've also recorded details of our image acquisition methods for those who are interested. Using our cohort, we developed a method to systematically evaluate EVLP radiographs, and here we introduced the concept of radiographic lung score, or RLS. To derive this score, we had a thoracic radiologist blinded to the clinical outcome select abnormalities relevant to EVLP radiographs. These are physical features that we could identify by looking at the X-ray images. For each of the 6 regions of a lung, they gave a severity score of 0 to 3 for each abnormality. So the RLS is the sum of feature severities by lobe for a maximum score of 3, or the sum across the entire image for a maximum score of 18. For example, suppose that for a given image, the atelectasis severity was 0 or none for the right upper lobe, right middle lobe, left upper lobe, and lingula, and had mild atelectasis in the right lower lobe and left lower lobe. The total RLS for this image would be 2 for atelectasis. This process would be repeated for the other 4 features. Looking at the results of our study, shown here are the distributions of the abnormality RLS in first and third hour radiographs. At both time points, infiltrate was significantly higher than the others. Atelectasis and nodule were about the same. And interestingly, we observed that the RLS for interstitial lines increased significantly in third hour radiographs. Next, we looked at RLS in individual lung lobes, each with a maximum score of 3. We found that while consolidation, infiltrate, atelectasis, and nodule had a tendency to occur in the lower lobes, interstitial line appeared to be more evenly spread out. And at this point, we wanted to know if our score would be useful in a clinical setting. So we correlated RLS with the existing diagnostic metrics that we know are indicative of donor lung quality. 2 of these important metrics are perfusate loss and oxygenation. With perfusate loss, we record the amount of circulating perfusate at the first and third hours of each EVLP case. Decreased volume is usually due to perfusate accumulating in the donor lungs on EVLP, so we often use that as a surrogate measure for edema. The oxygenation index is measured by subtracting the pulmonary artery partial pressure of oxygen from the pulmonary vein partial pressure of oxygen. Figures shown here are heat maps that highlight the extent of correlation between RLS and these metrics, indicated by Spearman R coefficients and the corresponding significance levels. Notably, we found that consolidation and infiltrate RLS were significantly correlated with higher perfusate loss and decreased oxygenation after 1 and 3 hours of EVLP. So this confirms the presence of lung injury at the physiological level. Lastly, we conducted logistic regression studies with 5-fold cross-validation and regularization to investigate the predictive value of RLS on top of oxygenation and perfusate loss. 2 clinical endpoints were studied here. First, the EVLP outcome, with lungs divided into the transplanted group and the declined group. And second, post-transplant outcomes in the recipient, which include lungs with recipient time to extubation of less than 3 days, lungs with time to extubation of greater than or equal to 3 days, and lungs deemed unsuitable for transplant. We can see that when RLS was combined with our existing metrics of perfusate loss and oxygenation, there was a significant improvement in model accuracy when predicting outcomes. We conducted this part of the study not only to establish and inspect our ground truth labels for downstream analysis, but also to develop a standardized scoring system in the future and share experience with other centers. Now that we have a part of our data set and ground truth curated, we wanted to see if we can extend the existing AI pipeline to include image analysis. In recent years, deep learning has been probably the most successful AI method and has been widely applied to various fields. Convolutional neural network is a class of architecture that is very good at image processing. Instead of trying to fit a weight to each input pixel, the convolution layer essentially slides a filter of weights across the input image and maps the features onto the next layer. So instead of connecting every unit in the previous layer to all the units in the next layer, the connections here are much more local in space. People have found this filter to really boost the performance of image classifiers. Although deep neural networks are the state-of-the-art machine learning models for unstructured data like images, the disadvantage is that they need massive data sets to learn their large number of parameters from raw low-level features. Listed below are a few examples of some popular deep learning data sets. Generally, large function spaces require more data so that more parameters can be learned. In total, we have roughly 1,400 EVLP radiographs in our dataset. In order to mitigate issues of having a smaller dataset, we attempted to apply transfer learning in our study. The idea is that before we train the algorithm with our own dataset, we pre-train it using a larger dataset. The figure here shows a general pipeline for transfer learning when people train image classifiers. At first, the weights in the model are randomly initialized. At the pre-training step, the model learns to see low-level features from the source dataset, and we preserve these weights when we fine-tune the model on our specific task. During transfer learning, we really just want the model to have generic foundational understanding of images. We'll pre-train our model using publicly available chest X-ray images. These are a few datasets available: CheckSPERT from Stanford and Mimic CXR from MIT. Each has around 200,000 frontal chest X-ray images. We started with data from National Institute of Health, which has 112,000 frontal chest X-ray images from 30,000 patients. This dataset has 14 radiographic labels, but for now, we pre-trained the model to only classify normal versus abnormal chest X-ray images. We're still at the initial stage of this study. These are pilot results that don't reflect the model's full potential. Some of the details of the model were included here for those who are interested. On the pre-training task, we got around 70% accuracy and AUROC using ResNet 50 and EfficientNet B0. These are results from our first attempts. We can probably get better performance by adjusting the model and tuning the hyperparameters. And so far, we have downloaded 184 images from our EVLP dataset. Although we have 5 radiographic classes, as seen in the previous analysis, our current subset is small, so we also train our networks to just perform binary classification for now, basically just classify normal versus abnormal EVLP radiographs. Our final results on the fine-tuning task was 62% accuracy using ResNet 50. This reflects performance on the subset of 184 EVLP images. Looking at the confusion matrices, the model was predominantly predicting class 1 to achieve this performance, since that was the majority class. When we have all the images downloaded and labeled, we're hoping to adjust the weights and really improve that model performance. And to summarize, we've systematically analyzed EVLP radiographs for the first time. We found radiographic information to reflect lung injury and predict transplant outcome. And deep neural network can further add value to donor lung diagnostics. In the future, we want to finish training using the entire EVLP dataset with 1,400 images. We want to adjust model hyperparameters, as mentioned, apply more advanced models to really improve that performance. And lastly, we're also thinking about clinical implementation in EVLP down the line. And that is the end of my presentation. I'd like to thank my supervisors, Dr. Kashafji, Dr. Wang, my committee members, Dr. Liu, Dr. Saipel, our radiologist, Dr. McInnes, my mentor in the lab, Dr. Sage, my lab mates, Dr. Ma, Ellie, and Yuxin EVLP team, and the rest of the lab members for helping with my study. Thank you so much for listening.
Oh, thanks so much, Bonnie. That was fascinating research. Now I'm just going to turn this over to our adjudicators to ask questions. Oh, you're still on mute.
Ah,
There we go.
okay, now I'm muted. That was a wonderful talk, Bonnie. So can you comment on, say, specific patient characteristics that improve performance? Is it possible for you to comment on that? Like, were there specific, say, characteristics like age, sex, etc.? Like, were there specific characteristics that were associated with better performance?
We found cause of death to affect the recipient outcome, and sometimes age, but not really BMI or sex. There's also type of death. We've done a lot of research on cardiac death versus brain death donors, although that's been sort of like proved that cardiac death can be just like the recipient outcome can be just as good. But right now we haven't really incorporated donor information in our so.
And then fluid status, did you have information regarding fluid status of the individual?
Fluid status as in edema in the lungs?
Well, so as measured by the central venous pressure, like CVP.
Yeah, I don't think
such parameters included as well.
I don't think that
might have an impact on edema in the lungs, and yeah.
Okay, that would be on the recipient end. Yeah, we haven't looked into that, but that could be a good direction. Thank you for the comments.
Sure.
I may ask a quick clarifying question, if that's okay, Bonnie. Appreciate the novelty here, especially around the labeling, which look like lots of fun for Dr. McInnes. How the preliminary results? What prediction task was that for? As a reminder.
For, you mean the labeling, the preliminary study?
The preliminary results you showed. I just need a reminder of what you were predicting.
Yeah, so we just wanted to see if using radiographic information would improve our prediction for recipient outcomes, whether that's EVLP outcome or recipient outcome. So before we dive into the whole AI study image classifiers, we want to see that these ground truth labels are actually meaningful.
So this was this was analysis of the X-rays alone.
Yeah.
Of the ex vivo lungs.
Yeah.
To predict, what was it, day 1 or 3? What was the outcome?
That was the time to recipient extubation, so the amount of time they were on ventilation.
Got it. Okay, that's interesting.
Yeah. Thanks for the question.
Hi, Bonnie, great work, fascinating, and I think a great application of like some form of automated chest X-ray interpretation, because it's all about application. I'm sure Dr. Fine can speak to that, about how it's all about tailoring it to like the task that you're trying to actually perform, and not just the raw automation of chest X-rays. I think they're complementary, but it's really important to tailor it. My question to you is, I mean, first I wanted to know, and or clarify that the chest X-ray task, if you were to ask a radiologist to just do it blindly, would they be able to perform that task, or would it just be 50-50?
As in, if we had a different radiologist, would they be able to confirm the labels?
So, because the label that you have does not come from the chest X-rays, right? So you're just correlating like a chest X-ray to a label that came from somewhere else. I'm asking, is this a task that a radiologist would be able to look at a chest X-ray and give you a label?
Right now the labels come from the EVLP X-ray images. So I'm not sure if I understood correctly or answered.
There's a labeling of the images, which a radiologist performs. That's how you establish ground truth for training your model, as I understand it. But then there's a label that's the outcome of the patient. That's from your kind of tabular data. Is that what you're referring to, Rashmi?
Yeah, exactly. That's exactly what I'm trying to figure out. I'm trying to see, because to me, like a radiologist will not be able to give you that final label, right? So that what I'm trying to say is that if you're 80.65, you're onto something, right? Because otherwise it's chance. So that's
Yeah,
what I get at there.
yeah. So our recipient or EVLP outcome label, that was just for the regression study that we did before image classifying like classification task. And for our eventual image classifier, we would want to also predict for the radiologist label, so all the 5 abnormalities, severities. For now, we just classified for abnormal versus normal.
Okay.
Yeah.
Okay.
Sorry. I hope I got that.
Okay, and a question just came in from an audience member in the chat. What was the inter or intra-reader variability of the radiologist evaluation, since this is not a typical X-ray we are used to reporting?
Yeah, so we've gotten that question quite a few times, and it is a very good suggestion. Right now, we just have one radiologist labeling all the images. And down the line, we want to incorporate 2, 3, 4 other radiologists, however many we can get, to see if there's any deviation in these different scores, and also to potentially look at consensus between different radiologists. But for now, we just have one. That was sort of like our very preliminary study to just take a look at all our images and come up with like a scoring system, since we never had one before. Thanks for the question.
Okay, if anyone has any other questions, they can include them in the chat or come off mute. Okay, looks like we're no questions. Well, just wanted to thank our incredible presenters for doing such a great job explaining their research, and extend our thanks to the 3 adjudicators who really helped us out. And I also wanted to remind everyone, we've got a speaker series in progress, and tomorrow we've got Dr. Mojgan Hode, who will be speaking about her research into using AI to research pain, which sounds really, really exciting, and we're looking forward to it. And also wanted to remind everyone in this meeting, if you haven't already become a T-CAIREM member, I hope you'll consider joining. All the details are on our website. All right, thanks again for coming, folks.